Really? Really? You live down If you forget something, you can't. just go
I know it,
and get
I know it. I have like one of those like old fashioned milk crates I keep in my car. I keep everything in there.
Oh, that's actually pretty smart.
It's like the perfect dimension to.
Yeah.
Yeah.
Put your computer, put your
Yeah.
backpack.
Yeah.
No, that's- Breakfast in a can? Breakfast in a can?
But yeah. One of those mornings.
Very good. We have two more people who need to take the exam. When they take the exam, it is graded and then the curve is figured out. I will curve it. You'll get your test back. So fingers crossed Monday. Sorry it took so long, but I don't want to give the test back when people haven't taken it. I think for probity's sake, that's probably the right thing to do within reason. So I apologize for the delay, but that's what probity has driven me to do. So I'm not trying to pat myself on the back. I'm just trying to make sure everyone has the same ability to take the test without any unwanted advantage, shall we say. We are talking about coagulation, how to deal with problems that emerge when you get clots appearing in the body in places where you don't want them. To deal with this, we're going to attack the coagulation problem at two places because coagulation occurs in two steps, so-called primary and secondary homeostasis. So primary homeostasis involves the formation of the platelet plug. There are drugs that prevent platelets from being so sticky and from forming plugs. Antiplatelet drugs are usually used to prevent clots in arteries. So if you want to prevent a clot in a coronary artery, you're going to use an antiplatelet drug. So the drugs here that are used to address this, those are the antiplatelet drugs. Then after you make that platelet plug, secondary hemostasis, you have the formation of these insoluble, long, rope-like fibrin polymers. And so you'll make the fibrin these will reinforce the platelet plug, and to prevent this from happening, you will use anticoagulants. Anticoagulants are going to be used to prevent clots in veins. So if deep vein thrombosis is a problem, you use an anticoagulant, not an antiplatelet. If you're trying to prevent clots in small arteries or other arteries, you'll use antiplatelet drugs. Anticoagulants for veins, antiplatelet drugs for arteries. So for secondary hemostasis, we have this rather complex and formidable pathway. We went over it quickly last time. We'll go over it once again. We see there's a common pathway that's used by both the intrinsic and extrinsic pathways. That pathway involves factor 10, clotting factor 10. Remember, all clotting factors are made by the liver. If you have liver dysfunction, your ability to clot your blood will not be as robust. So you have clotting factor 10. Clotting factor 10 is clipped into a smaller version that's active. It then makes the complex with clotting factor 5 and calcium and phospholipids found usually on the surfaces of platelets or other damaged cells. That will take prothrombin and will clip prothrombin into the very active serine protease thrombin. Thrombin will then clip several pieces off fibrinogen, and fibrinogen can now self-assemble into these rope-like polymers that are insoluble, known as fibrin. That's the common pathway. So it's really activating factor 10 that gets you fibrin polymers. How do we go about activating the formation of these fibrin polymers? Let's start with the extrinsic pathway, which is to your left. Focus on that with me, please. So in the intrinsic pathway, when you have trauma that damages blood vessels that will expose cells under the endothelial layer of blood vessels, like smooth muscle cells. These smooth muscle cells have a surface protein called tissue thromboplastin, otherwise known as tissue factor, in their membranes. Tissue factor is liberated into the blood and it binds with the soluble clotting factor, factor 7. When factor 7 binds to tissue thromboplastin, otherwise known as tissue factor, it forms a complex with calcium, also with phospholipids, either from damaged cells or from activated platelets, and it will cleave factor 10 into the active form. That's the extrinsic pathway. Extrinsic pathway. Keep in mind, every time you have a step, you amplify. So if you activate one molecule of thrombin, thrombin can cleave thousands of fibrinogens into fibrin. So if at every step you activate one molecule of factor 7, that can activate hundreds, several hundreds of factor 10s. Factor 10s can activate thousands of thrombins, and thrombins can activate tens of thousands or even millions of fibrin, cleave it into fibrin. So that's why we have these multi-step pathway. Each step involves an amplification step. Let's now talk about the intrinsic pathway. The intrinsic pathway. With the intrinsic pathway, you have the blood coming into contact with the collagen that's outside the blood vessel. You have the activation of prekallikrein into kallikrein. Kallikrein will activate factor 12 into the shorter form of factor 12 that is active. Factor 12, if it binds to a negatively charged surface, can do the same. Doesn't do it very well. So if we take Caitlin and we put her on the driving range and we hand her a putter, how far are you going to drive the ball, Caitlin? Yeah. Right. So you tee it up and you swing at it with a putter. How far are you going to drive the ball? Right. Maybe if we're generous, 50 yards. Sure. Okay. And normally you drive it, what'd you say, 200? 230? Okay. Sorry. Undercut you there. Okay. So having factor 12 do this by itself is like Caitlin trying to hit the tee with a putter. The ball will go far, but it won't go very far. It'll leave the tee, but it's not going to get very far at all. It gets a little help from kallikrein, essentially. Activated factor 12 will then do the same to factor 11. You get an amplification step there, which does the same to factor 9. You get an amplification step there. Factor 9 then joins with this protein called factor 8. Factor 9 and factor 8. Remember, factor 9 and factor 8 are the proteins that are defective in hemophilia. Factor 8 is defective in hemophilia A. Factor 9 is defective in hemophilia B, the genes of both of which are on the X chromosome. So hemophilia is inherited in an X-linked fashion. These two proteins with calcium and phospholipids will cleave factor 10. Now, thrombin is a multifunctional protein. Thrombin will also activate factor 5, which is used to help factor 10 produce more thrombin. It also will activate factor 8, which is used in the intrinsic pathway, and it activates factor 13, which is used to cross-link the fibrin polymers. So thrombin is a little bit of an equal opportunity offender, I guess you could say, when it comes to the clotting pathway. Now, there are two tests, laboratory tests that are used to determine whether these pathways are working. These tests will be important to determine how well our drugs are working. And again, I have a very dumb mnemonic to help you try and remember these. So when it comes to the extrinsic pathway, the extrinsic pathway, there's a test called the prothrombin test. Prothrombin test. Because of the way the test is done, the intrinsic pathway is essentially inactivated. Only the extrinsic pathway is activated. And the prothrombin test, nowadays, the way we used to do this test, you put the blood in a capillary tube, it's scored, and then you set your timer and you break it. And you break it. And when you break it, you see little threads that connect it. That tells you the blood is clotted. So you have to sit there and K5, K10, K15, K. You see the problem with that? You're watching the clock and not the tube. So you get a range usually with that test now. You mix the stuff together in a test tube. You put a drop on this machine. You close the lid. When it clots, the light can't go through it. And so it goes, and it tells you the time essentially. So you walk away, you push a button and walk away, and it does it for you essentially. It's just not fair. For the intrinsic test, there's the activated partial thromboplastin test. The activated partial thromboplastin test. And this is going to test the intrinsic pathway. Okay, dumb mnemonic. PTT is play table tennis. Where's table tennis played? Inside. So it's the intrinsic pathway that's tested. PT is play tennis. Where's tennis played? Outside. So it's the extrinsic pathway. Yes, I know it's dumb. If you're looking at me as if to say, really? Yep, yes, really. But sometimes dumb really helps you remember things. So play table tennis. Where do you play table tennis? Inside. Inside. So that's the intrinsic. Play tennis outside. So it's the extrinsic. Clots don't last forever. When an endothelial cell feels a clot curled up against it, it starts to make this protein called tissue plasminogen activator. Tissue plasminogen activator converts a protein also made by the liver in the serum called plasminogen into the very powerful protease plasmin. Plasmin degrades clots very vigorously, in fact. That's what's used inside vessels. If you're outside vessels, there's a protease that will activate plasminogen called urokinase. That will also make plasmin. And urokinase is made in the kidney, it's excreted in the urine. It's also made in various types of connective tissue, and what have you. It's a pretty common protease. Not as active a protease as TPA, but still pretty active. How do you keep blood from clotting in a test tube? This turns out to be a simpler question than you think, because what is the one cofactor that a lot of the clotting factors need in order to do what they do? The answer is calcium. There are several molecules that will bind up calcium very tightly. So you can use sodium citrate, which is a salt that's dirt cheap. You can also use something you may have used in your Chem 1 lab, ethylene diamine tetraacetate, or EDTA. Let's say EDTA. Ethylene diamine tetraacetate doesn't quite roll off the tongue very well, does it? Both of these are inexpensive. You can coat the inside of glass with them or plastic, and they'll keep the blood from clotting. We're going to look at a polymer called heparin that will keep blood from clotting. Heparin is used if you are taking blood out of someone and you're oxygenating it with some sort of extracorporeal system, like the ECMO system, extracorporeal membrane oxygenation system. Heparin is good for machines because when blood makes contact with metal surfaces and plastic, it can clot. You run heparin through that thing and run the blood through it, it won't clot. So heparin gets used a lot in hospitals if blood is being run through, say, a heart-lung machine or something like that, ECMO, what have you. You can also prevent blood from clotting by using direct inhibitors. We're going to see several of our inhibitors are factor 10 inhibitors. There's also some inhibitors that are direct thrombin inhibitors. And then a drug called warfarin or coumarin, which is an indirect inhibitor of clotting by inhibiting vitamin K mediated reactions. Vitamin K is a cofactor for an enzymatic reaction that occurs in the liver that is going to modify clotting factors 2, 7, 9, and 10. Without this post-translational modification, those clotting factors are not active. Or maybe it's more accurate to say they're very poorly active. Yeah, that's a better way to put it. They're very poorly active. So vitamin K antagonists work indirectly. We will look at both of those in our next section. First, let me stop, see if there's any questions to blood clotting, PT test, something like that. Yes. Yeah, yeah. There are induced hemophiliac conditions. If someone, for example, has acute liver failure, either because of sepsis or shock or something like that, they may have some sort of temporary condition where the liver's not producing clotting factors. Also, there are conditions where the clotting factors just get used up. For example, there's a condition called DIC, disseminated intravascular coagulation, that will burn up all your clotting factors. That is an induced hemophilia type condition. The way to do that essentially is to give this thing called concentrated thrombin factors. There's a thrombin clotting factor concentrate you can give quite easily. It's frozen, you thaw it, you then just give it to the patient. And usually that restores their clotting factors, temporarily at least. So the condition we call hemophilia A, B, and then the much more rare hemophilia C. Those are all purely genetic conditions. All right, so thrombosis refers to clots that occur within vessels causing tissue ischemia, causing infarction in the tissue and leading to tissue death. Do you know the difference between a thrombus and an embolus? Yeah, a thrombus forms in place. And if it stays in place, it's a thrombus. If it breaks off and floats throughout your bloodstream, it's an embolus. It's an embolus. And that embolus can get stuck somewhere. That's what this term embolism means. An embolus has broken off and has gotten stuck somewhere. So the CDC says that there are at least 900,000 confirmed cases of deep vein thrombosis. But it then says in the very next sentence that the number of cases is difficult to estimate because many of them are unreported. In fact, most of them are unreported. So the CDC's estimate, this is probably a high estimate, but probably not by that much, is that there are over 2.5 million cases of deep vein thrombosis in the US per year. Again, that's probably the high end. There are 10 million cases of so-called venous thromboembolism worldwide. That is from the WHO. That number hasn't changed that much from year to year. If it changes, it's a few thousand here, a few thousand there, something like that. Pulmonary embolism means you have an embolism that is lodged in the pulmonary vascular tree. This is very dangerous. It shuts off portions of your lung from circulation, causes that portion of the lung to potentially die. It also puts tremendous back pressure on the heart. And this is a life-threatening condition. So when you see PE, it does not mean physical education. It means pulmonary embolism, and that is a very serious case. There's some again, this is from CDC numbers. These are estimates because on autopsy, people may have a PE on autopsy, but is that what killed them? It's difficult to say sometimes. So the estimate is that there's over some 600,000 cases of pulmonary embolism per year, over 50,000 deaths per year confirmed from pulmonary embolism. And then pulmonary embolism contributes to another 150,000 deaths per year. Post-surgically, there are some over 11,000 deaths per year due to pulmonary embolism as a result of a sequela of surgery. What sort of conditions might be indications for antithrombotic therapy? Of course, deep vein thrombosis, pulmonary embolism. You're trying to prevent deep vein thrombosis or pulmonary embolism. And then heart stuff. If you have artificial heart valves or you have damaged heart valves, because you've made a surface upon which, a roughened surface upon which blood can clot, that is an indication for antithrombotic therapy. If you have atrial fibrillation, that's an indication for anticoagulation therapy because your atria are not working. Blood is not pooling in the atria. So a little dictum you need to remember is if blood pools, it's going to clot. Oh, excuse me. If blood pools, the risk of it clotting goes way up. If blood pools, the risk of it clotting goes way up. So if the blood pools, particularly in the atrial appendages, you're usually going to get a clot. That clot can then travel through the aorta, through the carotid arteries. It can cause a stroke, something like that. So if you've had a stroke, if you've had a transischemic attack, you're a candidate for antithrombotic therapy. And then if you have some sort of vascular graft, shunt, bypass, things like that, again, a roughened surface upon which clots can form, And then if you've had DIC, DIC is going to roughen the inside of vessels. That will also cause an increased risk of clots as well. So with some sort of endothelial damage or disruption of vessels, you get the formation of clots. If you have vessels that are damaged, blood still flowing through them, clots can still form. If you get a hemostatic plug, it can arrest breathing. Sorry, it can arrest the bleeding, but if you get clots that form in situ, they can cause embolic occlusion or occlusion in place. That can cause tissue ischemia or infarction. So to reduce risk factors, you want to reduce the risk of vascular injury. To reduce platelet adherence and activation, we can use platelet inhibitors. To prevent the formation of thrombus, we can use anticoagulants. And if we have an unwanted thrombus in place, those can be dissolved with drugs called fibrinolytics. So once again, to reissue this pathway, once again, we're going to attack the problem at factor 10. We're going to attack the problem at those factors that require vitamin K, factors 2, 7, 9, and 10. We can attack the problem at thrombin. And as we said before, we're going to attack the problem at factor 10 as well. This simply gives you an idea of what happens when fibrinogen is clipped to fibrin. So if you look at fibrinogen, that's a cartoon of what it looks like. It gets essentially trimmed. And now it can stack up one against the other in this polymer like this. That polymer is going to stretch essentially in this fashion, like that. That's what causes fibrinogen to produce fibrin that is insoluble and is cable, even rope-like. When you digest a fibrin polymer, plasmin will clip in between here. These bits here that cross-link, it can't digest those. So it's going to produce this fragment called a D, capital D, dimer, a D dimer. Blood levels of D dimer are an excellent indicator of whether or not you have clots that have been forming. And consequently, D dimer is used extensively in healthcare to determine if someone has had clots kicking around. So if you're on an anticoagulant, but your D dimer is high, that suggests it's not working. You need to up the dose or switch to another anticoagulant. I'm going to pause right here, take a drink of water, and see if any of you have any questions that are mulling around in your head. Yeah, the US, because we live longer. Becomes more of a problem as you get older. So places, developed countries where people live longer, it becomes more of a problem. I think it's fair to say that parts of the world where you have lots of vitamin K in your diet, you're more prone to clots. Yeah, beyond that, I think that's really all I can say. Places where people go barefoot a lot, they will tend to get clots in their foot and they get older, in their feet. This is a pretty universal problem, and it's mainly a problem when you get older. So as we see here, so this is the clinical criteria that you're going to use to determine if someone needs an anticoagulant. This is called the CHAD-VASC scoring system. CHAD-VASC scoring system. So if they have any of these conditions, they get points. So if they have congestive heart failure, any stage, that's a point. If hypertension, that's a point. Now, hypertension, if it's well controlled, some physicians may look at that and say it's well controlled, it's been well controlled for years. That, no, I'm not going to give you a point there. So that one, you might want to put a caveat there of how well it's controlled. Age, equal to or older than 75 years of age. Getting back to your point there, Bracken. Do you have diabetes? And then also, how well controlled is it? Have you had a stroke, transischemic attack, or some sort of thromboembolic event? 2 points, that's a biggie there. Vascular disease of any kind, if you had peripheral arterial disease, prior myocardial infarction, aortic plaque, something like that. Are you aged 65 to 74 years of age? And are you postmenopausal female? And if your score is 1 or 0, usually you'll be fine. You may be recommended that you take a daily aspirin, or if, depending on your family history, it may be recommended you go on some sort of oral anticoagulant. If your score is 2 or higher, usually you'll be put on some sort of oral anticoagulant. And the risk stratification is shown here. You can see as your CHAD-VASC score increases, your risk for a stroke increases per year progressively as your scores increase. And it is clear that if you treat people with anticoagulants, antiplatelets, and what have you, you can decrease their risk of stroke, heart attack, things like that. Maddie, did your hand go up or were you stretching? You're stretching, okay. Stretching's good, stretching's good. Now in your notes that I gave you, I left my binder upstairs, I'm sorry. Don't remember what page it is, but there's a page that shows you the drugs we're going to talk about. Thank you, Roger. Yeah, okay, here it is. Page 88 and 89. Yeah. So page 89 is a list of the antifibrinolytics. Sorry, the fibrinolytics. So the fibrinolytics essentially take advantage of this protein called tissue plasminogen activator. Tissue plasminogen activator has been cloned, sequenced, well understood, overproduced, and now it's sold commercially. And by putting mutations in the gene, you can make proteins that have longer half-lives and that are more active. So these will take fibrin, they convert plasminogen to plasmin. They take fibrin and they produce these fibrin degradation products. So the first of these is alteplase. Alteplase goes by the trade name Activase. This is recombinant native tissue plasminogen activator. You can see it does not have a very long half-life. Therefore, it is quite controllable. Sometimes these drugs are called clot busters. Clot busters. These are enzymes. You give them intravenously. Alteplase is FDA approved to treat heart attack, stroke, or even in some cases, peripheral arterial disease, if you get clots in your lower extremities and tissue ischemia is a big risk. When you give these drugs, you have to give the drug gradually. And of course, a big risk with this drug is bleeding. So you have to watch the patient like a hawk for eternal bleeds. This is really important, particularly with stroke patients. Patient comes in and they've had a stroke and they're showing all the signs of paralysis and what have you of a stroke. You're giving this drug, the nurse, and it's the nurse's job, has to sit there with the patient and monitor them. If they show any signs of an internal bleed, their blood pressure starts to crash, they show signs of internal pressure starting to increase in the brain, patient starts to go into seizure, something like that, you pull the drug faster than you would run away from a rattlesnake, essentially. So these drugs, you have to use them with a great deal of caution. They're very useful, very powerful, but they can cause bleeds, substantial internal bleeds. So they have to be watched like a hawk. Now, these other drugs, besides alteplase, are mutant versions of alteplase that are more active and have a longer half-life. So there's retiplase and tenecteplase. Retiplase and tenecteplase. So retiplase goes by the trade name Retivase. This, as you can see, has a longer half-life than alteplase, about 3 times longer than alteplase. This is only FDA approved for heart attacks. And this stuff is only going to work in a heart attack if you get it into them quickly. If you get it into them quickly, it can dissolve the clot and open it up. Now, you still have a vessel that's damaged, that's going to clot again, but gives you time essentially to get them to the cath lab and get a stent in them. And that will usually seal everything up. Tenecteplase, as you see, has an even longer half-life. That is also used, well, it's also FDA approved for myocardial infarction. It's used predominantly in the ICU to clean out hemodialysis catheters and things like that get plugged up with clots. So those are your fibrinolytics. Fibrinolytics. If your fibrinolytic is starting to run away and you need to tamp it down, the antidote is called aminocaproic acid. Sometimes abbreviated ACA. That's the antidote to fibrinolytics that are going too hard, too fast. Yeah. Most cardiologists who give alteplase, who work in cath labs, prefer alteplase because it's a lot more controllable. And the way Dr. Gupta described it to me, he said, you're putting this tornado into the, that's a word he used, tornado. You're putting this tornado into the vessels. Do you want a tornado that's this big that you can hold in your hands, or one that's this big that you have to hug like this, you can't control nearly as much? And so I asked him, are there conditions under which you'd want a more powerful one? He said, no, because if you want more, you just give more. Of the alteplase, it's got a 5-minute half-life. It's done. So even if it's overdone, it's not going to cause a patient that much damage because it's going to be inactivated so quickly. So that's usually what they prefer. Now, I did talk to a guy at University of Pennsylvania, an old friend of mine, John Epstein. John prefers retiplase. because he sees people come in with big clots. He says alteplase can't handle the big clots. Retaplase, also retaplase, these have a higher affinity for the clots. These will actually go in, bind the clot, and he says, and they'll burrow right through the clot. And he said you can get tissue reperfusion much faster. So he prefers retaplase. I haven't talked to anybody that prefers tenecteplase yet, but maybe they're out there because it does get used. It's mostly used, at least in the ICU, for cleaning out hemodialysis catheters. All right, what's the big thing you're going to watch for with those drugs? Bleeding, internal bleeding. And signs will be blood pressure starts to crash. You start to see nausea, vomiting, things like that, what have you, all those signs like that. Now, thrombin, getting back to thrombin, is also an activator of platelets. There is a receptor on the surface of platelets called PAR1 that binds thrombin. So when thrombin gets activated, thrombin not only wreaks havoc amongst the denizens of the clotting pathway, it will also activate platelets, which makes some physiological sense, given that if you're going to make these fibrin cable-like molecules, you need a platelet plug to reinforce. So thrombin's also going to activate platelets. In that spirit, there are medications that actually block these thrombin receptors on the surfaces of platelets. And they are used as well. We'll get to some of those. So if you see those, that way you know essentially. And one of them is on your list on page 88. It's called Vorapaxar. Vorapaxar is a thrombin receptor antagonist. So this is to remind you essentially of the armamentarium that your body has to work with. We have natural anticoagulants. One of those is going to feature prominently when we talk about heparin next, antithrombin 3. You then have things that promote endothelial health. They're antiplatelet substances made by endothelial cells, nitric oxide, prostacyclin, prostaglandin I, prostacyclin, and then various things that chew up clots, TPA, which activates plasminogen to plasmin. So the first anticoagulant we need to talk about is heparin. Heparin is used extensively in healthcare, extensively. So our dear friend over here, Brooke, probably is going to have to get her ankle worked on at some point in time. And when she gets her ankle worked on, she's probably going to have heparin. When her ankle gets worked on, she's probably going to have to be given some heparin after her ankle gets worked on to prevent clotting that occurs in the leg as a result of some sort of lower extremity surgery. So heparin is really heavily used in healthcare. Heparin is a polymer. It's a polymer of charged sugars. And heparin comes in two types. There's the unfractionated heparin, and the unfractionated heparin has short polymers and long polymers and everything in between. So that's the unfractionated. Then there's a product that is just short polymers of heparin, and that is called low molecular weight heparin. Low molecular weight heparin. Unfractionated heparin has relatively unpredictable pharmacokinetics. Low molecular weight heparin has very predictable pharmacokinetics. So why is unfractionated heparin used? Why? I'll tell you why. Heparin has a very good antidote available to it. That antidote is called protamine sulfate. Unfractionated heparin is inactivated by protamine sulfate in a 1-to-1 ratio. So inactivating heparin, if you need to inactivate it, if it's unfractionated, is dead easy. 2, unfractionated heparin is not excreted by the kidneys. Because it's not excreted by the kidneys, it's safer to use in someone with compromised kidney function. That's the other reason it's used. Third reason, it's dirt cheap. That's the other reason it's used. So heparin, when it comes in these long polymers, is able to bind to a protein in your blood called antithrombin 3, and it supercharges it. And antithrombin 3 gloms onto thrombin and shuts it down. And then the shorter polymers of heparin bind to factor 10 and shut it down. And this essentially is your polymer of heparin. It's that penta sugar repeat that just gets repeated over and over and over again. And that's heparin. So it binds to antithrombin 3. Antithrombin 3 gloms onto thrombin. It's a match made in anticoagulation heaven, and thrombin gets shut down. And you pretty much shut that common pathway down cold. Antithrombin 3, as you see, will inhibit not just thrombin, but several other components of the clotting pathway. And it inhibits plasmin as well, for that matter. And essentially, it takes hemostasis and puts hemostasis in stasis. So it inhibits activation of platelets by thrombin because it shuts down thrombin. Inhibits activation of clotting factor 13 that stabilizes fibrin because factor 13 is activated by thrombin. Inhibits factors 12 and 11 and 9 and 10 and 2. And prevents formation of fibrin. And unfractionated heparin. To determine how well it works, you're going to use the activated partial thromboplastin test. That's a test you will use for heparin, unfractionated heparin. Low molecular weight heparin, you don't need to test. Its pharmacokinetics are so well understood and predictable, you don't need to test it. This drug has a longer half-life than fractionated heparin because you have shorter polymers. It inhibits factor 10, doesn't really inhibit thrombin by activating antithrombin 3. Binds to antithrombin 3 poorly. But it shuts down factor 10 very, very effectively. So it's used really extensively. So some of you want to be physical therapists. You will get people who've just had knee replacements. After a knee replacement, you get sent home with a box, and that box has in it vials of low molecular weight heparin. And the nurse, one of the nurse's jobs is to teach you to inject subcutaneously. And you have to take that until the doctor tells you to stop taking it. And so you will have patients essentially on low molecular weight heparin after they've had shoulder surgery or maybe knee replacement or maybe partial knee replacement, like my sister's getting right now, and other types of surgeries for which you'll be doing the rehab. Now, the main low molecular weight heparin that's used is enoxaparin, trade name Lovenox, but it's in generic now, so it's pretty much enoxaparin. You can see that's used both for DVT prevention. So, and also DVT therapy. And SQ means it's given subcutaneously. Heparin is not an oral product, must be injected. The low molecular weight heparin is absorbed very effectively subcutaneously. The other product is deltaparin, goes by the trade name Fragment. It's not used as much, but it is available and is used. The third product is tenzaparin, Inahep, but tenzaparin, the manufacturer has stopped making it. So by the time you guys start practicing, this product's not going to be in existence anymore. Already hospitals are not using it because they can't buy it anymore. Stocks are disappearing. Hypersensitivity to heparin has been reported. So people, if they inject it, they'll get chills, fever, and hives. How do you test if someone's allergic to heparin before putting them on heparin? Yeah, test dose, exactly. Or you could do a so-called scratch test. You put a little bit on a needle, you just give them a little scratch. You see a wheel and flare, that tells you better not give them any heparin, better give them something else. So yeah, you can do a test dose. And that's in the protocol for the hospital before they go home. The nurse is supposed to administer a test dose, observe it. If they don't react to it, then you instruct them how to give a dose. And usually the nurse will watch them give their first dose and coach them through it. And some people really hate needles and they have to get over that. Or if you just can't bring yourself to do it, you can hire a nurse to come in and do the shots for you. You have to pay them though, because they're professionals, they don't work for free. I believe some insurances will cover that though. Kaiser covers that. Don't know if Blue Cross Blue Shield does. Let me get back to you on that one. I'm not an expert on insurance. I don't know that much about insurance. I don't think anyone is. It's so darn complicated. Now, another drug on your list is a drug called fondaparinux. Fondaparinux is a pentapeptide, so it's very heparin-like. But fondaparinux is essentially a heparin alternative. So if you want to use something besides heparin, fondaparinux is a potential stand-in. Fondaparinux also has to be given subcutaneously through injections. It's not an oral product. So here's a little comparison of native and low molecular weight heparin. And you simply see that the bioavailability of one is quite good. The other is kind of lousy. One, you have to use laboratory monitor to test it. The other, you don't. Standard heparin can be administered intravenously. Low molecular weight heparin usually is not administered intravenously, subcutaneously. It's absorbed very well subcutaneously. Also, its absorption is gradual, which is what you want. Whereas with intravenous low molecular weight heparin, you get this big dose of low molecular weight heparin. You don't want that. Because the bioavailability of standard heparin is so lousy, you can give it intravenously. And your bleeding risk is slightly lower with low molecular weight heparin. All anticoagulants have as their side effect increased risk of bleeding. All. Some have higher risks than others, but they all have that risk. And so fondaparinux is used for deep vein thrombosis, acute pulmonary embolism to treat those. You can also use it for prophylaxis. And it's also used for this thing called heparin-induced thrombocytopenia, which is the one really severe potential side effect of heparin, which we don't have time to talk about. So Monday, next week, we'll talk about HIT, heparin-induced thrombocytopenia. And then we will get into the other anticoagulants. And then that will lead us into the antiplatelet drugs. And after that, we then talk about pain relief.